So we have talked about cholinergics. Now anticholinergics. Name suggests they are opposite to cholinergics, means you block the cholinergic effects. Basically, remember, we have these misconceptions about antagonists. Because of these systems, adrenergic and cholinergic, we get this impression that antagonists, they have some effect. And it is true. Antagonists, they have an effect, but there is no action. Understand this difference. Action is what happens as a consequence of binding of the drug to the receptor. Okay? So if it comes to definition of antagonist, there will be no effect. There will be no action. Because antagonists, they are having only affinity. There is no intrinsic activity. So antagonist will not produce any action, but not producing any action will also produce an effect. Effect is what happens at the larger level. But here, because there is already some activity going on, that activity will be inhibited and that will be the effect. So these are the anticholinergics that we have. Classical is atropine. Atropine, from Atropos belladonna. Atropos belladonna. Atropa belladonna. Belladonna is a French word. It's basically belladonna, beautiful lady. And why the name was given? I read that Cleopatra used to put atropine in her eyes. Atropo belladonna. Why? Why? It was perceived in those days that this increases the beauty. How? This actually produced mydriasis. And from there comes this term, badi badi aankhon wali ladki. So when we say badi badi aankhon wali, one of the impression is the pupils are dilated. And that became a sign of beauty. I searched for a long time for this. Why is it so? That if I have mydriasis, I look beautiful. Why should it happen? And then after many years, I could find it out. This is basically psychology. If my pupil dilate by looking at somebody, this means I am in love. This is natural connection in our brain. It's like a mother would like to have a very clear picture of a son. So this is natural reflex. When I like something, I look at it, my pupil will dilate to get more light, to make picture more clear. This is normal brain reflex. What is psychology is when I look at somebody and I see that by looking at me, her pupil are getting dilated. I get this impression, he is in love with me. And remember one thing, everything that I love is beautiful. This is another perception in my brain. Everything that I love is beautiful. So this has a long history of how name belladonna was given. But this is what I could collect. Otherwise, I was very intrigued with this word belladonna. But this is how it happened. This atropine plant was very famous in India. Actually, this was used more for asthma. They used to put it on this fire and they used to smell the smoke. So this used to cause bronchodilation, and traditional medicine and particularly those tantrics and all those people, they use this for asthma, and that is why it became so popular and they became very famous. Because remember, there is nothing more dangerous as an experience than this feeling of asphyxia. You have to experience it sometimes. Very, it's horrible. That is what we say in myocardial infarction. What is more problem? It's not the pain. This is that asphyxia, that fear of death that is carried with this asphyxia. And if somebody can remove that asphyxia, then he is no less than God. And that is how many of these traditional healers, they became famous. Whenever you'll get attack of asthma, acute attack of asthma, you go there and they give you something and you inhale this smoke and you feel relaxed. That person has to be famous. So this has a long history, this plant has a long history. We have semi-synthetic derivatives. Atropine methonitrates, quaternary ammonium. Here also you'll have to keep a watch on which are having tertiary amines and which are quaternary, because the quaternary ones, they would have limited utility. Homatropine, hyoscine butyl bromide, another quaternary. Ipratropium, another quaternary. Tiotropium, these are all quaternary compounds. Synthetic compounds are mydriatics like cyclopentolate, tropicamide. Vesicoselective, this is a very nice classification. It gives me some idea about how they were developed, and it gives me, this is actually also therapeutic classification. If I have to write therapeutic uses, it would become very easy for me. So synthetic compounds are mydriatics, cyclopentolate, tropicamide, and if I have to add amongst mydriatics and I don't take this consideration of synthetic and semi-synthetic, then homatropine will also come here. Homatropine also is a mydriatic. When we say, remember, all anticholinergics are mydriatics, but that is for which we are using them. This is this classification, like vesicoselective. And remember, suppose I say vesicoselective oxybutyrate we give for these problems. This gives us an idea also that even though we are saying that all these organs are having M3 receptors, but there are some more division of this M3 also. There is variability in M3 also, because these drugs, they are having more effect on this organ or more effect on that organ. That cannot be justified by simple distribution of these drugs. We are not giving them, instilling them locally in the bladder. We are giving them orally. But the effect is more on bladder compared to GIT, compared to dryness of mouth. This means even though we are saying that M3 receptors are right from eyes to genitourinary tract, they are all M3 receptors, but there are further divisions amongst M3 also. This gives us an idea. So these are all vesicoselective and these are anti-Parkinsonian. We also call them centrally acting anticholinergics. Trihexyphenidyl benzaxole, procyclidine, bipyridine, benztropine is there, many more are there. These are anti-secretory, antispasmodics. Quaternary compounds are propanthelin, oxyphenonium, clidinium, simetropium, isopropamide, glycopyrrolate, more commonly used, glycopyrrolate. Tertiary amines are dicyclomine, valethamate and pyranzapine. We talked about pyranzapine, that equal efficacy in decreasing the gastric acid secretion. So these are tertiary. Tertiary means more lipid soluble, more distribution. Quaternary means no lipid solubility, less distribution, and that is why more localized effect. So remember this classification, this will help a lot. These are the effects. Again, if you know the effects of cholinergic drugs, you don't have to remember anything else. And there I have told you, you have to remember the effects on those systems. What is the effect on heart? What is the effect on GIT? What is the effect on genitourinary? What is the effect on eye? What is the effect on skin? On exocrine glands? Is 7, 8 CNS. If you remember them, you know these effects in both cholinergic as well as adrenergic system. So here whatever you have read in cholinergic is opposite to that. What will happen to sphincter pupillae? This is passive mydriasis, not active. Passive mydriasis. Why? Because I have blocked the effect of acetylcholine on M3 receptors. So constrictor pupillae is not working and they are in balance. Constrictor and radial muscles, they are in balance. There is a balance that is maintained. So if I paralyze my constrictor pupillae, the radial muscles will predominate. There will be mydriasis, but it's not active. This is passive mydriasis. I am not contracting any muscle. I am just paralyzing some muscle. Ciliary muscles, again there will be relaxation and this time there will be cycloplasia. Remember, in case of cholinergic we say spasm of accommodation. Ciliary muscle is contracting. Here that is paralyzed. So this is cycloplasia, we call it. Trabecular meshwork, what will happen? Reduced aqueous humor. What will happen to intraocular pressure? This will increase. Cardiovascular, opposite to that, there will be increased heart rate, increased conduction, increased contractility, everything will increase. In bronchial muscles, there will be bronchial relaxation, smooth muscle relaxation, bronchodilation. There will be dryness of secretions. Actually, that is one of the reasons when it comes to therapeutic uses, we don't use these drugs for asthma. We don't use these anticholinergics very commonly for asthma, except in cases of asthmatic cough in children. Otherwise, they are used in COPD. GIT, smooth muscle, reduced tone and motility. Sphincters, they are increased tone of sphincters. Gastric glands, reduced secretions. Intestinal glands, reduced secretions. So everything is opposite to what with detrusal muscle is relaxed. Trigone of sphincter is contracted. Salivary glands, there will be less secretions. All these secretions will be reduced. Dryness. CNS, mild sedation. Prevention of motion sickness, we use this drug, hyoscyamin, for that. Reduction of tremors, we are using it for that purpose. CNS in high doses, these are the effects that is seen, and it would become very difficult to differentiate between cholinergic and anticholinergic. This will also cause restlessness, confusion, hallucinations, delirium and coma, and there also I told you in toxic doses. So in high doses, very difficult to differentiate. Inhibition of sweating, reduced heat dissipation, cutaneous vasodilatation. So there would be hot skin. There is no effect on skeletal muscles because neuromuscular transmission is mediated by nicotinic receptors, and atropine, remember, is anti-muscarinic. It is not anti-nicotinic. It is a specific blocker of muscarinic effects of acetylcholine. If you want to block everything about acetylcholine, you will have to give neuromuscular junction blockers also like D-tuberculin, and you will have to give ganglion blockers like hexamethonium. Then only you can say all the effects of acetylcholine are blocked. Autonomic ganglia, minimal effect. Adrenal medulla, minimal effect of these. And this comes to what are the therapeutic uses of these drugs. Sinus bradycardia. Remember, rarely we realize this fact. The patient comes with bradycardia, severe bradycardia, heart rate is 30, 40. We don't know what to do. What you will find very commonly is given adrenaline. Very dangerous. Even I tell you, when I was working in one hospital, my superintendent used to say in resuscitation, I used to give adrenaline intracardiac. But he told me don't do that because he used to have problems in the court. What he said, it is very difficult to prove that this death is not because of adrenaline. If the adrenaline remains in the myocardium, there will be fibrillations. And this can be cause of death also. If you give intracardiac injection of adrenaline and it goes in myocardium, the person is going to die. There will be arrhythmia. So then he told me, if any way you have to do, otherwise remember, in resuscitation what is more important is that prick that restarts the heart. It is not the drug that is doing anything. The heart is in still. If you give that drug in the cavity of the heart, how would it work? So he said, if you have to give something, give atropine. So even in cardiac resuscitation, this is even better than adrenaline. If it comes to that, it should be used in sinus bradycardia. There is no other drug basically. You cannot stimulate the heart by adrenaline. AV nodal block, naturally atropine. Vasovagal syncope, atropine. These are all cholinergic effects, na? So you have to block them. Refraction testing in eyes, remember? When you go for checking of your number, they put some drops and ask you to sit outside. What we give? We have written fundal examination tropicamide, in refractory testing atropine, homatropine, cyclopentolate. Atropine, no. Once you give atropine, instill it in the eyes, the effect will stay for 1 week. You will have blurred vision. The mydriasis will stay for a week. This is how I used to remember it. This had to be mugged up. So mydriasis for 1 week, psychoplasia for 3 days. That is what you remember. So you are gone. Cyclopentolate, we would say mydriasis for 2-3 days, cycloplasia for 1 day. So cyclopentolate accepted to some extent. Otherwise, even this homatropine, cyclopentolate is for 1 day. Homatropine, we used to remember 3 days mydriasis and 1 to 2 days cycloplasia. And cyclopentolate 1 day. Tropicamide, this has effect for 3 to 6 hours. Perfect. Mydriasis for 3 to 6 hours, and that is why actually in fundal examination where you don't need cycloplasia, it is used. But it is said that cycloplasia with the tropicamide is not very consistent. Sometimes it happens, sometimes it does not happen. But otherwise this would have been very nice drug for that purpose. But what they are using for refractory testing, they are using cyclo. You can go and check in the ward what are they using, I don't know. In the not ward, in the OPD, you go and check what are they using for refractory testing and what are they using for fundal examination. Iridocyclitis, uveitis, iris iridocyclitis, irido-uveitis. Why are we giving there? Because remember, it is inflammation, like we were talking about. They are giving steroid after cataract also. We don't want inflammation. So if inflammation is there, there are chances that some fibrosis will take place and iris will stick either to cornea or to lens. Big problem. So what we do, we keep giving mydriatic and miotics alternatively so that it does not stay in one position for a long time. So there we use all these drugs, or sometimes the adhesion they have taken place. Then how to remove them? Again you do the same thing. Respiratory system COPD, ipratropium, tiotropium, there are other regions also because remember beta receptors, beta agonists are given in asthma, because in asthma the problem lies in the larger trees, tracheobronchia. In COPD, periphery is more affected. But just remember, ipratropium, tiotropium, they do not have any CNS effects. They are quaternary compounds. More than that, we are not giving them orally, we are giving them inhalational. So the effects are very local. And so ipratropium, tiotropium, they are used in COPD. Bronchial asthma, I have told you, it is not the drug that is given. Anticholinergics are not given in bronchial asthma, but in, as I told you, in children, asthmatic coughs, immediate effect, you can use ipratropium, tiotropium. Otherwise, they are not indicated in treatment of asthma. For asthma, we go for beta agonist and steroids. Asthma is an inflammatory disease, so we have to go for steroids inhalational. And along with that, if you want immediate effect, we go for beta agonist for bronchodilation. Pre-anesthetic medication, yes, there I told you atropine we have, it can be given, but glycopyrrolate, again the same reason, glycopyrrolate also is quaternary compound, so effect will be very local, it will not go to the CNS. And why are we giving pre-anesthetically? Remember the same reason, we want secretions to dry up, otherwise the person will drown in his own secretions. When the person is undergoing anesthesia, you are doing intubation, you are doing so many things. If there will be so many secretions, the person will drown in his own secretions, we call it. So we give something to dry up the secretions, and that is glycopyrrolate. And then if therapeutic uses in GIT, intestinal colic, irritable bowel syndrome. Remember, even though there used to be a preparation, Lomotil, I remember this was given for diarrhea. This used to have diphenoxylate, that was an opioid. So later on this was withdrawn because of so many cases of addiction. This became a substance of abuse. But if you see in Lomotil, this used to be a combination of diphenoxylate and atropine. And this used to be a question for us. Why atropine is added with diphenoxylate in this preparation? Nowadays, remember, no drug to decrease the peristalsis is to be given in diarrhea, because diarrhea is considered protective. You are expelling the organisms, harmful organisms that are in the GIT. But in cases like irritable bowel syndrome, if you have to go for, then the drugs like dicyclomine are given. In biliary colic, we go for hyoscine butyl bromide. Dicyclomine is not found to be very effective in biliary colic. In GIT, in urinary colics, dicyclomine is very effective. Traveler's diarrhea, again dicyclomine, because in traveler's diarrhea it is very simple type of diarrhea, there is no dysentery, and it is said infection is very less. So there, and you may need to sometimes decrease the movement, because you have to, the name is traveler's diarrhea, but this does not mean that it is because of traveling. It is because of change of food or water, that this simple diarrhea has taken place, mild infection. There sometimes you will have to stop it, and that is why actually we used to give Lomotil in traveler's diarrhea. But now that is not available. Symptomatic relief. Overactive bladder. Remember, this was a side effect of cholinergic drugs. You go for oxybutynine. Urge, tolterodine. Incontinence, solifenacin. It's not basically, if you remember that classification, I classified vesicoselective. So all of them you can write, any of them you can write, it would be better than atropine. When we say vesicoselective, means any of these conditions. The conditions are overactive bladder, urge, incontinence, neurogenic bladders. In any of them, any of these drugs can be oxybutynine, tolterodine, solifenacin, all these can be used. And what are they doing? They are basically relaxing detrusor muscle. They are constricting trigon of bladder, so the urine will remain in the bladder. That is the reason why it is given. Then in Parkinson's disease, I told you, Parkinson's disease, we use centrally acting anticholinergic drugs like benzaxole, benztropine, biperidine. This in Parkinsonism you will read, and drug induced Parkinsonism also. Antipsychotic drugs are there, haloperidol and others are there. So they cause, their most important problem is extrapyramidal side effects. Extrapyramidal side effects are like Parkinson-like symptoms, tremors, rigidity. So there we use these drugs, and actually these are the drugs which are indicated. We do not go for drugs like atropine. We go for centrally acting drugs. They have very specific activity. And then these are clinical conditions, say motion sickness. I told you hyoscine scopolamine is given. Patches also are available before the journey you put them. Vestibular disturbances, again hyoscine. Tablets also are available and patches also are available. So they suppress vestibular pathways. Organophosphate poisoning. I told you the effects will be cholinergic. And so the drug of choice is atropine, nothing else. Organophosphate poisoning, lethal condition. Lethal. The person would die. You consume insecticides. So what you have to give, and remember, I worked for a long time with nurses from Kerala, and I was in Miraj. There used to be so many orchards of grapes. When we used to go to ICU, before that everything was done. We just simply used to ask how much atropine is given. Experts in managing these cases of organophosphate poisoning, the technician will come and intubate, nurse will start atropine, because time is very important in organophosphate poisoning. Time is very important. You have to do it fast. Cholinergic crisis, opposite to myasthenic crisis, atropine is the drug that is given. Pre-anesthetic medication, I have told you, prevention of vagal bradycardia, again atropine. Excessive salivation, glycopyrrolate. Hyperhidrosis, excessive sweating, again glycopyrrolate or oxybutynine also is found effective. Peptic ulcer, these I told you, pyranzapine is supposed to be equally effective as ranitidine, as two blockers. And this is in a nutshell. Atropine is major clinical use is bradycardia, organophosphate poisoning, pre-anesthetic medication. Tropicamide, fundus examination. Cyclopentolate, cycloplegic refraction. Ipratropium, COPD, asthma, as I told you, rarely. Tiotropium, again maintenance treatment of COPD, longer half-life. Hyoscine, motion sickness. Dicyclomine, intestinal spasm, irritable bowel syndrome. Oxybutynine, overactive bladder. Solifenacin on derifenacin, urge incontinence. So these are major uses of these drugs. These are adverse effects. Now you know already all pharmacological actions of these drugs, they are adverse effects. Mydriasis is a side effect. I told you, the person becomes completely helpless, blurred vision, cannot do anything. Cycloplasia, again you cannot see the far objects, it's a side effect. Blurred vision, photophobia because of mydriasis. Precipitation of acute angle closure. Remember, if the person is giving you history of attacks of glaucoma, don't use these drugs. The person will land up in acute angle closure glaucoma. Remember this mydriasis, I told you at that time that in mydriasis all the muscles of iris, they are in the periphery. They are crowded in that angle only. And because of that, there is no drainage of aqueous humor. So if already the angle is narrow, don't use them. Tachycardia, big problem. Palpitations, arrhythmias, very rare, but all these are side effects. Dryness of mouth and throat, reduced salivary and mucosal secretion. Remember, this causes pain. The disease xerostomia, we call it, na? If there is no salivary secretion, you cannot even eat. That's a big problem. It becomes very painful. Thickened bronchial secretions. So you're constantly coughing and nothing is coming out. Typical effect of. And remember, sometimes I have very bad experiences. If you see the contents of medicines, then just check it should not have anticholinergic. This used to be very troublesome, clidinium. I was, it seems, doing MBBS or after that, then I realized, I always thought that clidinium, it must be some coloring agent. But when I read about it, this is an anticholinergic drug. This has very strong anticholinergic effect. So when you see the drugs which we use for cough and cold and this and that, you should keep a watch on what are the contents in that. What is the use of those contents? So everything will dry up. Difficulty in expectoration. As I told you, thickened. It gets sequestered in the trachea. It does not come out. Typical. The person is coughing in anticipation that something will come out. Xerostomia, constipation, reduced gastric secretions and abdominal distension. These are all side effects. Urinary hesitancy. Urine will not come out. Urinary retention. Worsening of prostatic symptoms. Remember, enlargement of prostate, you get the same symptoms. Another contraindication of anticholinergics. If the person is having enlarged prostate, you will have to bring him in the night to the hospital, because the person will not be able to urinate, and then you will be required to intubate, put the catheter, not intubate. So dry skin, because there is no sweating. Hot flushed skin, there will be increased temperature because of vasodilatation. Hyperthermia, as I told you. Sedation, because of hyoscyamin, this causes sedation. Drowsiness, restlessness, irritability because of CNS symptoms, confusion, hallucinations, delirium, coma. Those who have taken scopolamine for motion sickness, they can very well understand the effects. There's typical slight headache with confusion, with dryness of mouth. There is eyes are hot. You feel like wash them all the time. Very bad experience if you take a tablet of scopolamine for motion sickness. Confusion, memory impairment, delirium, and falls due to blurred vision and cognitive impairment. So history of fall you will get in these people. This is anticholinergic syndrome. These are typical symptoms of dry mouth, hot dry skin, mydriasis, blurred vision, tachycardia, urinary retention, constipation and delirium. This is a phrase: dry as a bone, blind as a bat, red as a beet, hot as a hare, mad as a hatter, full as a flask. So this is, I told you, these are classical drugs where people, they had a lot of experience. And remember, when we are giving atropine in organophosphate poisoning, these are the symptoms we look for. There is no plasma levels that you can measure that this much atropine is sufficient, this much atropine is sufficient. When the person is coming with cholinergic crisis, the person is wet, sweating, hypotension, and when we give atropine, then these are the symptoms actually look for. The skin should be dry, it should not be wet at all. And the most important symptom that you go and check for, pupil should be dilated. If the pupil are not dilated, that means you need more atropine. So these are the symptoms basically which guide us in the management of organophosphate poisoning. There is no specific dose that this much atropine is to be given. You give atropine and then keep checking. You have to keep the pupil dilated. That is the concept in organophosphate poisoning. There should not be sweating at all. If you see sweating, pupil is coming back, infuse more atropine. Thank you very much. So this completes our cholinergic and